So, welcome to the second part of the lecture for the urinary system. Today we're picking up where we left off last time, talking about cells of the nephron. So in each nephron, the final part of the ascending limb of the nephron loop is going to make contact with the afferent arterioles that are serving that renal corpuscle. So because the columnar tubular cells in this region are going to be kind of crowded together, they're called the macula densa. So alongside the macula densa is the wall of the afferent arteriole, and this is going to contain modified smooth muscle fibers called juxtaglomerular cells. So together with the macula densa, these are going to constitute the juxtaglomerular apparatus, or the JGA. And this juxtaglomerular apparatus is going to help to regulate blood pressure within the kidneys. Then the distal convoluting tube is going to begin a short distance past the macula densa. So in the last part of the distal convoluted tubule and continuing into the collecting ducts, there are going to be two different types of cells that are present. Most of the cells are going to be principal cells, and these are going to have receptors for both antidiuretic hormone, or ADH, as well as aldosterone. And these are going to be two hormones that are going to regulate their functions. So there are all then a smaller number of intercalated cells, and these are going to play a really important role in the homeostasis of blood pH. The collecting ducts are going to drain into a large papillary duct, and this is going to be lined with simple columnar epithelium. So moving forward now to discuss glomerular filtration. This is the first step in urine formation. So the fluid that enters the capsular space is going to be called glomerular filtrate, and the fraction of blood plasma in the afferent arterioles of the kidneys that become glomerular filtrate is going to be the filtration fraction. So although the a filtration fraction of about 16 to 20% is going to be normal, the value is going to vary considerably between both health and disease. So on average, the daily volume of glomerular filtrate in adults is going to be about 150 liters in females and about 180 liters in males. This is, again, largely due to differences in size. So more than 99% of the glomerular filtrate is going to return to the bloodstream via tubular reabsorption. So only about 1 to 2 liters are going to be excreted as urine. That brings us then to the filtration membrane, so how this filtration is occurring, or through what we're filtering, basically. So the filtering unit of a nephron is going to be the endothelial capsular membrane, and together the glomerular capillaries and those little podocytes are going to form a leaky barrier known as a filtration membrane, or an endothelial capsular membrane. This is going to be a sandwich-like kind of assembly, and this is going to allow for the filtration of water and small solutes, but it's going to prevent the filtration of most of those big, larger blood plasma proteins, and as well as the blood cells themselves. So substances that are filtered from the blood across 3 filtration barriers, so 3 levels of filtration that are occurring here. We have the fenestrations that are part of that glomerular endothelial cells. We have the basement membrane of the glomerulus, and then we have the little slits between those little pedicles. So those are our 3 layers of filtration. The glomerular endothelial cells are going to be quite leaky in nature, and this is because they're going to have those large fenestrations that we mentioned. And these are going to be anywhere from 0.07 to 1 micrometer in diameter, and that does sound small, but as far as a filtration, the active filtration is concerned, it's just a little bit larger. So this size is going to allow all solutes in the blood plasma to exit the glomerular capsule. It's going to exit the glomerular capillaries, but it's going to prevent the filtration of blood cells. So then located among the glomerular capillaries and in the cleft in between the afferent and efferent arterioles are going to be these mesangial cells. And these are going to be contractile cells that are going to help to regulate glomerular filtration. Next is the basement membrane. This is a layer of acellular material that's going to be between the endothelium and the podocytes. And this is going to consist of minute little tiny collagen fibers and some negatively charged glycoproteins. So the pores within the basement membrane are going to allow for water and most small solutes to pass through. However, the negative charge that we find on those glycoproteins is going to repel plasma proteins, most of which are anionic. And so this repulsion is going to hinder the filtration of these proteins. And then extending from each of the podocytes are thousands of little foot-like processes called pedicles, and these are going to wrap around glomerular capillaries. So the space that's in between these pedicles are going to be the filtration slits, and a thin membrane, also known as the slit membrane, is going to extend across each filtration slit. This is going to allow for the passage of molecules between that are in the diameter range of 0.006 to 0.007 micrometers. So these are very small molecules that are able to pass through this membrane or this slit. All right, this is going to include things like water, glucose, all kinds of vitamins, as well as amino acids and very small plasma proteins. Also things like ammonia, urea, and other ions. So less than 1% of albumin, which is the most plentiful of the blood plasma proteins, is going to be able to pass through those slits. And this is because the diameter of albumin is going to be 0.007 micrometers, which is just barely too big to fit through that fenestration slits there. So now moving forward, we're going to look at the principles of filtration. This is going to be the use of pressure to force fluids and solutes through a membrane in the same, and this is going to be the same in glomerular capillaries as what we see in blood capillaries elsewhere in the body. However, the volume of fluid is going to be filtered. That's filtered by the renal corpuscles is going to be much larger than that which we would see in other blood capillaries of the body. And this is going to happen for three reasons. The first is that the glomerular capillaries are going to be are going to have a very large surface area for filtration. And this is because they are long and extensive. So those mesangial cells are going to regulate how much surface area is available. So when these cells are relaxed, the surface area is maximized. And glomerular filtration is able to be quite high. So the concentration of these mesangial cells is going to reduce the available surface area, and glomerular filtration is also then going to decrease when these contract. The second reason that we have such a high volume of filtered fluid in these renal corpuscles is because the filtration membrane is going to be quite thin and porous. So our glomerular capillaries are also going to be about 50 times leakier than what we would see in blood capillaries in most other tissues. And this is mainly because of those large fenestrations that we've mentioned. And then our third reason is that the glomerular capillary blood pressure is going to be quite high. So because the efferent arterioles are going to be very small in diameter, they'll be smaller than the afferent arterioles. And so this resistance to outflow of blood from the glomerulus is going to be quite high. So as a result, blood pressure in those glomerular capillaries is going to be considerably higher than what you would see in blood capillaries elsewhere in the body. So with that, then, that brings us to the concept of net filtration pressure, right? Glomerular filtration is going to depend on three main pressures. One pressure is going to promote filtration, and then two pressures are going to oppose filtration. Glomerular blood hydrostatic pressure is the blood pressure in the glomerular capillaries. This promotes filtration by forcing water and solutes in blood plasma through the filtration membrane. Right, this is about 55 millimeters of mercury in measurement there. Next, our next pressure we have is capsular hydrostatic pressure. This is going to be the hydrostatic pressure that's exerted against the filtration membrane by fluids that are already in the capsular space and renal tubules. Our capsular hydrostatic pressure is going to oppose filtration and is going to represent a back pressure. This is going to be about 15 millimeters of mercury in pressure. And then our final pressure that we have is blood colloid osmotic pressure. This is going to be due to the presence of proteins, things like albumins, globulins, and fibrinogen in plasma proteins. And this is also going to oppose filtration. And the average blood colloid osmotic pressure is going to be, in the glomerular capillaries, is going to be about 30 millimeters of mercury. So our net filtration, finally, our final net filtration is going to be our glomerular blood hydrostatic pressure. That's going to be about 55, minus our capsular hydrostatic pressure at 15, minus the blood colloid osmotic pressure. So that's going to leave us at about 10 millimeters of mercury pressure for our net filtration pressure there. So with that, moving forward then to talk about glomerular filtration. This is driven by blood pressure, and it's opposed by capsular hydrostatic pressure as well as that blood colloid osmotic pressure. So water and small molecules are going to move out of the glomerulus, and in one day, between 150 and 180 liters of water are going to pass out of the glomerular capsule. So our glomerular filtration rate is going to be the amount of filtrate that's formed by both kidneys each minute. So homeostasis is going to require the kidneys to maintain a relatively constant glomerular filtration rate. If this rate is too high, then substances are going to pass too quickly and are not going to be reabsorbed. If this rate is too low, alternatively, then nearly all of these substances are going to be reabsorbed, and some waste products are not going to be adequately excreted. So the mechanism that regulates our glomerular filtration rate is going to adjust blood flow into and out of the glomerulus, and it's going to alter the glomerular capillary surface area that's available for filtration. The glomerular filtration rate is going to be on average about 125 mils per minute in males and 105 mils per minute in females. And it's controlled by three primary things. We've got renal autoregulation, neural regulation, and hormone regulation. And we're going to discuss each of these coming up. So for starters, we have renal autoregulation. Right? This is bringing us then to the myogenic mechanisms. Right, this is when smooth muscle cells and afferent arterioles are going to contract in response to elevated blood pressure. So as that blood pressure rises, our glomerular filtration rate is also going to rise because renal blood flow is going to increase. However, if the elevated blood pressure stretches the walls, however, the elevated blood pressure is going to cause the walls, the afferent arterioles, to stretch. And so in response to the stretching, smooth muscle fibers in the walls of the afferent arterioles are going to contract. This then narrows the arteriole's lumen, and as a result, the renal blood flow is going to decrease, therefore reducing our glomerular filtration rate to the previous level. We also have something called tubuloglomerular feedback, and this is going to occur in the macula densa, and this provides feedback to the glomerulus. So a high glomerular filtration rate is going to diminish reabsorption. The macula densa is going to inhibit the release of nitric oxide, and this is going to cause the afferent arterioles to constrict. Next, we have the neural regulation of our glomerular filtration rate. So with regard to the neural regulation, like most blood vessels in the body, those that are found in the kidneys are going to be supplied by the sympathetic autonomic nervous system fibers, and these are going to release norepinephrine, which is going to cause vasoconstriction in the smooth muscle fibers of the afferent arterioles. So at rest, the sympathetic stimulation is going to be moderately low, and the afferent and efferent arterioles are going to be dilated. And that renal autoregulation of the glomerular filtration rate is going to prevail. It's going to be what's going to regulate things primarily. However, with moderate sympathetic stimulation, both afferent and efferent arterioles are going to constrict to the same degree. Blood flow then is going to flow into and out of the glomerulus is going to be restricted to the same extent, and this is going to decrease glomerular filtration only slightly. With greater sympathetic stimulation, however, as we would see during exercise or hemorrhaging, vasoconstriction of the efferent arterioles is going to be predominant. So as a result, blood flow into the glomerular capillaries is going to be greatly decreased, and our glomerular filtration rate is going to drop. So this lowering of the renal blood flow is going to result in two consequences. It's going to reduce urine output, and it's going to, in an attempt to help conserve blood volume. And two, it's going to permit a greater blood flow to other bodily tissues. So last but not least, then for our three things that are going to regulate our glomerular filtration rate, we have our hormonal regulation. This is going to be two main hormones that are going to contribute to the regulation of glomerular filtration rate. We've got angiotensin II. This is going to reduce the glomerular filtration rate, and atrial natriuretic peptide, ANP, is going to increase glomerular filtration rate. So angiotensin II is going to be a very potent vasoconstrictor, and this is going to cause narrowing of both the afferent and efferent arterioles, and is going to reduce renal blood flow, thereby decreasing our glomerular filtration rate. The arterial natriuretic peptides, our ANP, are going to relax the glomerular mesangial cells, and this is going to increase the capillary surface area and therefore increase our glomerular filtration rate. So ANP is going to be secreted in response to stretching of the atria, and this is going to occur when blood volume is going to increase, and this therefore stimulates the secretion of ANP. So glomerular filtration rate is going to rise, therefore, as the surface area increases. So here, for your studying needs, we have a table reviewing the regulation of the glomerular filtration rates. And then moving forward, we're going to then start discussing the tubular reabsorption and secretion. We're just going to start with this, discussing this now. We'll finish it up next lecture. The normal rate of glomerular filtration is going to be so high that the volume of fluid that enters the proximal convoluted tubule is going to be about half an hour is going to be greater than the total plasma volume. So reabsorption is going to return most of the filtered water and many of those filtered solutes back into the bloodstream, and this is going to use both active and passive transport methods. Tubular secretion is going to be the transfer of materials from the blood and tubule cells into the tubular fluid, and this is going to help to control blood pH, and it's also going to be really important in eliminating other substances from the body. So secretion is going to help to manage pH, and it's going to rid the body of various toxins and foreign substances that need to be cleared out. So that's our reabsorption and secretion. Those are our second two steps in the formation of urine. Here we have a handy-dandy table looking at various substances that can be filtered, reabsorbed, and secreted. How much of these we're doing filtering, reabsorbing, and secreting each day. So now let's take just a quick look at the various routes that are available for reabsorption to occur. So substance being reabsorbed from the fluid in the tubule lumen can take one of two routes before entering the peritubular capillaries. It can move between adjacent tubule cells, or it can move through an individual tubule cell. So although the renal tube, along those renal tubules, there are going to be tight junctions that are going to surround and join neighboring cells to one another. This is very similar to what you would see for the plastic rings that hold a six-pack of beer cans together, or soda, whatever it is you're drinking. But those old plastic rings that used to be a thing, I guess they're not as common now. So the apical membrane, the top of the beer cans in this particular instance, are going to be in contact with the tubular fluid, and the basolateral membrane, the bottoms and sides of the beer cans, are going to contact the interstitial fluids at the base and sides of those cells. Fluid can also leak between the cells in a passive process known as pericellular reabsorption. So even though the epithelial cells are going to be connected by those tight junctions, the tight junctions between those cells in the proximal convoluted tubules are considered to be leaky, and therefore are going to permit some reabsorption or reabsorbed substances to pass between those cells into that peritubular capillaries. In some parts of the renal tubules, the pericellular route is going to be thought to make up about 50% of the reabsorption of certain ions and the water that accompanies them via osmosis. We then also have transcellular reabsorption. And in this type of reabsorption, a substance is going to pass from the fluid that's in the tubular lumen through the apical membrane of a tubule cell. It's going to move across the cytosol and then into the interstitial fluid through the basolateral membrane. So that is the last of the slides that we're going to cover for today's lecture. So as always, if you have any questions, comments, or concerns, please feel free to contact me or ask after class. Thanks so much.